see everybody, and forgive us, this is our very first run, so if you didn't get handouts, I'll post them tomorrow on our Facebook page so you can have this to follow up. We're also recording this, and we will upload this to Dr. Perrin's YouTube at a later date, but so excited you're all here, and I hope you enjoy your evening. So without further delay, I want to introduce Dr. Laurie Perrin, who many of you know as a staple of our community at Flagstaff OBGYN, but also the founder of Slow and Steady 360, which is a full lifestyle medicine program. If you haven't gone to our website, I recommend checking it out, sns360.com. But Dr. Laurie Perrin. Oh my gosh. Oh! My heart is like bursting. I can't even tell you. Wow, thank you all for coming. I'm so glad to be here. And you know, it's funny because they say when you're really nervous about a talk, you're supposed to imagine your audience naked or something. So I'm so fortunate because like I've seen so many. Like I don't even have to be nervous. So I mean, really, it's so fabulous. So I'm just some of you even yesterday. My name is Laurie Perrin. I'm an OBGYN in Flagstaff. I've been in Flagstaff since 2003, practicing obstetrics and gynecology, and actually I just started delivering patients that I've delivered, which if you ask me is like the je ne sais quoi of an obstetrician's career. Like that just feels amazing to me. So luckily they're more like 21 than 17, I'll just say, so for the most part. So, you know, I feel like for myself, I'm a bit of a lifelong learner. And so after I started practicing OBGYN and raising my kids, and I moved here when my kids were 1 and 3, and I delivered a lot of babies here of friends of mine, so our kids grew up together. And about 10 plus years ago, my kids are starting to get into adolescence, and I decided to get boarded in pediatric and adolescent gynecology. So, you know, why not? When you're going through it, let's just learn as much as we can about it. And I feel like I've been really fortunate to be able to offer that service in Northern Arizona because there's nobody else here that does any kind of, especially the adolescent gynecology. And I've been so thankful for my pediatric partners in town who start with them and then send them my way, and that's been a really huge joy. And to be honest, kind of helped me get through the teenage years with my kids, learning about how to talk to them and learning really how to bring humor into the picture, because when they just want to go lock themselves in their room and not have anything to do with you and you want to take it personally, you got to kind of figure out some humor. So adding that to my repertoire felt really important to me at that time. I'm currently 56 years old, and around the time I turned 50, I started to think like, both my grandmothers lived into their mid to late 90s, and I thought, oh, I'm kind of halfway, I think, here. So that was about 6 years ago, and there weren't much happening with hormonal treatments at that time, like we'll talk about tonight. And so I was really trying to figure out ways to age gracefully and do it more through lifestyle instead of through medication. And so I remember meeting some girlfriends down at the annex and being like, I found these HIIT workouts, you guys. We all have to start doing HIIT workouts, you know? And they're 20 minutes, and they're really good for your strength and for your bone density. And, you know, I started to kind of delve into the workouts that could be really helpful in nutrition and mindfulness and yoga and strength and flexibility, and therefore Slow and Steady 360 was born. And so I've done, a lot of you obviously participate in that with me, and I've done things where I've done 6-month programs that are mostly email-based. I have 2-week no sugar challenges, and most recently I've been doing a lot of individual counseling and coaching, because for me, I really find like meeting the individual where they are, and I've sort of learned over the last few years that you can put out masses of stuff, but to really enact change, I find that you have to kind of go to the individual. You know, you really need to work with the person, because we all have different challenges and different obstacles and different goals that we want to achieve. And so me meeting with people individually has been really rewarding for me, and I hope really helpful for them as well. So, and I see a fair number of you out there who I work with regularly, and so hopefully that's the case. And so, then lastly, what kind of happened for me was that in September I decided to attend the National Menopause Society meeting in Chicago, and a huge light bulb went off for me when I was there. I mean, first of all, it was like really the latest and greatest in the country, and not just the clinicians that were like me that were there, but the researchers that are doing the research, and the researchers that have gone back and debunked some of the old studies that we'll talk about tonight, and have brought forth so much new information, and so much just information about the safety of potential hormone therapy, and they talked about lifestyle a lot at that conference. Like, it was not devoid of lifestyle one bit, and so I thought to myself, okay, this is like a match made in heaven, you know? You have like the perimenopausal and menopausal mixed with the lifestyle, because I really feel like if we're gonna age gracefully, and we're gonna be on the floor with our grandkids and being able to travel and be active, both needs to happen. And so you can take hormones, you cannot take hormones, but probably you need to be moving your body and eating well and practicing mindfulness. So we're gonna get into all of that tonight. What I'd like tonight to be is I am gonna do a little bit of a dialogue or a chat. I wanna talk with you guys about some of the history and the definitions and what's available out there. And then for the last 30 to 40 minutes or so, I really do want to open up, not just for questions to me, which I'm happy to field, but just conversation with our community of women who are obviously looking for some information. And really, tonight for me is really, like Shannon said, this is our first gig, and I really hope that we go somewhere with this, you know, whether it's other discussions that are more targeted towards particular subjects, or a menopausal health fair, or support groups that meet once or twice a month. But I really want to know what you want. It's not what I want, it's what the community wants. And so that's really my whole goal for today. So, okay, a couple questions for you guys. So I'm going to ask you to raise hands. So how many people in the room are in their 30s? Okay. How about 40s? Okay, 50s? Okay, we'll just do 60 and above. Okay, awesome. So we have the gamut. We really have the whole gamut. So how many of you feel like you have experienced at least one perimenopausal or menopausal symptom? Okay, so look around. Okay, so this is kind of cool. So if you are between the ages of 35 and 55, 100% of women, or I should say people with ovaries these days, will experience perimenopause and menopause and some symptoms. Like, you can't help it. You go through it. It's actually the exact opposite of the reproductive cycle of puberty, right? So, and we all talk about puberty, right? Talk about our kids who get locking themselves in the room, or rolling the eyes, or, you know, all the mood swings, and we talk about it all the time. We talk about it with our friends, we talk about it with our partners at work, we talk about it with our kids. But somehow we don't talk about the other end of the spectrum. We don't talk about so openly what's happening during perimenopause and menopause. And if you're like me also, and you had your kids in your early to mid 30s, they're in puberty when you're in perimenopause. So that's a lot of hormone going on. I can tell you. And we don't always deal with our kids in the way we want to, because, oh my gosh, I just lost my cool and I'm so irritable, and you know, you have 15 things going on, and it's really hard to manage, and yet you feel like you can't talk about it, right? So tonight, that ends. There is no shame in what we are going through. There is not one bit of shame. There is nothing wrong with us. You are not crazy. You do not need antidepressants. It's not you. It is what is happening to your body. It is happening to your hormones. And much like we'll talk about a little bit later, like when things happen after you have kids, if you've had kids, there's a lot of times in that scenario as well where your emotions kind of take hold of you, and it's really hard to manage. So that's what tonight is about. So Okay, so let's go on to talk about like what even is, when is menopause, what is menopause, and what is perimenopause? How do we know that we're in it? And that's what we need to figure out. So the definition of menopause is essentially 12 months with no natural menstrual period consecutively. So not if you have an IUD, not if you had an ablation, not if you're on birth control pill continuously. None of those count. 12 consecutive months without having a period, you are technically in menopause. And then you are in menopause for the rest of your life. So, okay, so that's the 12 months. And a lot of times, like, so what happened to me was I went 9 months. And I thought, I'm so close, I'm like home free, period. Okay, now my clock starts all over again, back to starting at month number 1, and there we go. Now, at the time that happened to me, I'm gonna be really honest, I was 54 years old, and I thought to myself, I wonder if it's the slow and steady stuff. The reason I got my period, like I wonder if that stuff's actually been helping some of my metabolism and some of my hormones, and actually brought that period back on. And I don't know if that's the case or not for sure, but I will tell you there's a lot of research out there about it that's starting to come out that's showing a lot of the lifestyle factors are helping us with the hormonal, huge hormonal swings. So we will get there. Okay, so big question, like most things we do in medicine, the question is, do we check labs or do we not check labs? So I'm going to stand here in front of all of you and very firmly say, we do not check labs. Period. And I'm going to go as far as to say that if you go to a practitioner and they want to check your labs, that you very sweetly and calmly thank them for their time and leave. Or finish your visit, but I would not get your labs drawn. And there's a couple of reasons why. And I surely would not do like a cheek swab or something like that. I have a lot of respect for allied health, naturopath, chiropractor, whatever have you. I have so much respect, and I don't want to say that anybody is doing anything wrong, but I will tell you with the knowledge that I have come in the last few years that if you are seeing somebody who's checking your labs, that is not somebody who's very well versed in perimenopause and menopause treatment. So I think you just have to know that. It's a little bit of a waste of money, and a lot of times what happens after you get those labs checked is that you leave the follow-up appointment with a baggie of supplements that cost you about $250, and maybe some pellets shot in your butt of hormones, or bioidentical hormones, which we will talk about later. None of that is appropriate for perimenopause or menopause treatment. So I urge you. And you know, I think that it kind of makes me laugh a little bit because this is pretty much might be the only thing in medicine I can think about where we actually need to be listening to the patient. And not saying like, oh, you have all those symptoms of hypothyroid? Well, let me just get your labs. You know, I'll tell you if you have hypothyroidism. You know, I'll tell you if you have an autoimmune disease. I'll tell you, because in medicine, we check labs. That's what we do. But we don't in perimenopause. And the reason is that the hallmark of perimenopause, like we talked about similar to puberty, are these huge swings in your hormones. And so the truth is, if you get your labs drawn on Monday at 10 a.m., and I check them again at Thursday at 4, they're different. So you cannot tell somebody that they're going through something by checking their labs. You actually have to listen to your patient. You have to ask questions. You have to ask leading questions. And you have to bring out what's going on with them so that you can then help figure out how to treat them or how to help them. So one of the things the question is with perimenopause is when does it even start? And I've noticed over the past number of years that I would start to have women come into the office and say, for their annual exam, kind of in their mid to late 30s, and I'd say, how are your periods? You know, we talk about all this kind of fun stuff, so tell me about your periods. And they'd say, well, you know, they're okay. I kind of spot a little bit. Then I get my period, and then I have this like spot, and it's so annoying. And I'm like, yeah, you guys have heard me say it. Welcome to your late 30s, early 40s. Like, that's what happens in our periods, and that's the start of the hormonal shifts and swings. And just a quick life cycle of your menstrual cycle, what you can expect if you haven't already gone through it, is you'll start to get that spotting, and then kind of in the mid to late 40s, your cycles will shorten a little bit, more to like that 25-day. Mine got to 21 days. That's really fun. That's fabulous. And you feel like you have 7 days of like a clear head and like where you feel like yourself again. Great. So it's 21 days, and then essentially they'll start to lengthen, you'll start to skip. Like I said, some people go 3 months and then get a period back, or I went 9 months. And a lot of times what you'll start to notice during these times is that you'll start to have all these symptoms, and then all of a sudden they go away. And I just had someone in the office last week, they're like, oh, my symptoms went away. And I'm like, well, you're about to get your period, because your hormones are coming back up. And so you're going to menstruate. And sure enough, you menstruate and you feel better, and then you go into the swings again. So let's just start to go through like what it is that we feel. And so I'm a little bit of a head to toe person, but I put these very purposefully more in a systems type of approach, because I think it's a little bit easier to wrap our head around. And so we'll just start with the first one. So cognitive changes, so those memory lapses and difficulty concentrating, brain fog. You go into the kitchen, you're like, what was I even trying to get here? I can't even remember. Very similar to what people go through when they're pregnant. That's what I call fetal shunting, for those of you who have babies with me. When the babies, I always say they pull that brain cells from you, but the truth is that pregnancy, and especially also if you breastfeed, those are very low estrogenic states of your body. And so you're essentially, breastfeeding especially, it really mimics what your life is going to be like in menopause. And so if you're able at that time to pay any attention to what's happening in your body, you can have a sense, sorry, Deb, is that gonna be bad? That's going to be bad for you, Deb, really? Okay, sorry. It's very true, though. So the things that happen, and especially this brain fog, and just feeling like you kind of can't concentrate. Emotionally, this kind of takes the gamut. Mood swings, anxiety, depression, severely heightened PMS. You think to yourself, I have not really had that bad PMS, and all of a sudden, like, rage comes during PMS. And I know, right? Yeah, no kidding. I know, and a lot of times you'll go to your primary care physician and you'll talk, and then they'll put you on an SSRI. They'll give you Zoloft, they'll tell you, you're having some increased anxiety and you're feeling all irritable. How about you take the SSRI? Which to some extent could be a great treatment and maybe all you need, but it also might not be the full picture. And so I think that this is just like an easy, sometimes a Band-Aid, and I think it's not really doing us the service that we need. Physically, what happens? Tons of stuff. I think I'm like waiting to have the hot flash right now, personally. But like from hot flashes to night sweats, weight gain, mostly that central weight gain that you're sort of like, why is this coming? I've been eating the same and exercising the same, and all of a sudden, now I have the spare tire. Sleep disturbances. And sleep disturbances, if you ask me, it's kind of the beginning and the end of everything if you think about it, right? And so if you're not sleeping well, then that kind of cascades your entire day. So now your hunger hormones are off, you make much poorer choices of what to eat, you really don't have the energy to move your body, you're irritable, you can't concentrate, you're exhausted, and then you might go and have a cocktail or eat a gummy or take some Benadryl or do the things because you have to sleep, and then those have their own host of issues that it just sort of snowballs. And so when you have these sleep disturbances, and a lot of times people fall asleep just fine with perimenopause. It's not the falling asleep, and surely the alcohol or the gummy kind of helps with that, but it's what happens when you wake up at 3 in the morning to pee, or when you have to wake up 3 times in the middle of the night to pee, because you drank tea at 7 o'clock at night. So, this is all real, and it is happening. And again, you feel like, I can't even complain about it, I can't talk about it, and, and the truth is, we have to. We have to be talking about it. It's happening. It's happening to all of us. We all raised our hand. So this is very real. So cardiovascular-wise, heart palpitations and cardiovascular disease. And one of the interesting things that happens with regard to heart disease that we've really learned over the last 20 years is that Every cell in our body has estrogen receptors, and especially in our lining of our blood cells, the endothelium. With lack of estrogen, you have an increased risk of plaque formation. And so literally just by having your estrogen levels decrease, you have an increased risk of heart disease, whether you have healthy lifestyles or not. It doesn't matter, just by not having that hormone. And even, we'll talk later, when we do add in some hormone, it's not physiologic enough to always affect the plaque. So that's also where that lifestyle stuff comes in. But this is all stuff that's happening in our bodies during this phase. Urogenital, near and dear to my heart, because I talk about this all the time with you lovely ladies. And so there's a whole, I could do an entire talk just on this. It's now called Genitourinary Syndrome of Menopause, GSM, and it is for real. You guys know it's for real. I'm not kidding. So this is where you have the vaginal dryness or the incontinence or the urinary frequency, changes in libido, and it's not just that you're irritated with your partner or that your vagina is dry or that you're exhausted and you really have no desire to hop in the sack, because you have no desire to hop in the sack. It's true. And, we talk about certain things, like one woman that talked at the menopause conference, I love what she said. I always ask people when they talk to me about decreased libido, okay, but if you go to the party, can you have fun at the party? The truth is, the bottom line is, can you orgasm? Because if you can orgasm with somebody, by yourself, with a toy, I don't care. If you can orgasm physiologically, you're fine. But again, you might not have any desire to be hopping in the sack or having orgasm. And sometimes it takes a lot longer, or you need different type of stimulation. But a lot of it has to do with the changes in your body and the changes in that genital system. And the one physician at what did she say? She had something funny too. She said, you can't go to the party if you can't get through the door. That was a good one, I thought. I'm using that, Lauren Stryker. I'm definitely using that. And that's kind of where, and we talk, one of the things we'll talk about, and I don't know if I'll come back to this again maybe later, but one of the changes that happen vaginally, and it also happens with breastfeeding, is that I say my spiel with breastfeeding is that, when you're lactating and you're producing breast milk, your natural estrogen levels are really low. And I believe the reason for that, physiologically, is that if you're providing sole sustenance for one being, you really shouldn't be procreating for another being, right? That's a lot for your body to do. And so it makes sense that that vaginal tissue kind of gets, it sort of gets atrophic and it loses its elasticity and it's not all luscious and, wanting to take in. It just is sort of which is how most of us feel, except our husbands at the 6-week visit are hey, let's go, honey, back on the horse. You're like, oh, God, no. So GSM is real, and there's lots of things that we're going to talk about to help with it, because it's not fun. And it's not even, I talk a lot about intercourse, but it's not just people who are sexually active. The urinary frequency or the feeling like you go to wipe and it feels like sandpaper, even if you get that really plush Charmin that we love, still feels like sandpaper, something's going on down there. I have a lot of women that come in and tell me they feel like they have infections. I think I get a yeast infection every month right before my period. Yeah, nope, not a yeast infection. You need vaginal estrogen, So these are the things that are happening that we're noticing. Quick other couple things, musculoskeletal joint pain is very real. Who knew that frozen shoulder comes with perimenopause? Look at that. Something new, you learn something new every day. And just joint stiffness in general. And that's interesting to me because opposite to pregnancy is a very progesterone-dominant phase, and progesterone makes our joints really lax, and we talk about that a lot during pregnancy. But in perimenopause and menopause, your progesterone levels, just as your estrogen levels, plummet. And so that stiffness, when you're all sitting here for an hour and then you're going to go to get up, you're going to feel the stiffness. So that's it's very real. This is not happening. You're not just getting old. This isn't in your head. This is happening to your body. Lastly, we talk about dermatological things. This is also a huge thing with skin changes, hair loss, hair growth. I don't know about you, but 47-year-old, I was walking around with huge zits on my chin, so embarrassing. You're like, I feel like I'm in puberty. It's just, again, these like crazy, massive swings of our hormones. So the question is, what do we do about it? All right, so before we talk about what to do about it, I want to do a little history. I graduated medical school in 1995, so this May I have my 30-year medical school reunion, which I'm very excited about. Yay! And one of the interesting things for me being in practice this long is I feel like I've been very fortunate because I've gotten to see this like really interesting kind of swing when it comes to treating women in menopause. And when I started, every single woman, if they were 50 or older, was on hormones. Back in the 90s, in the early 2000s, they were on Prempro. And we'll talk about what Prempro is. Well, I'll just talk about it now. So Perrin was the estrogen, and essentially that's an estrogen that comes from estrogenized female horses, mares, which is where it gets its name, Perrin. That's why it's called Perrin. So, and then the Provera that we used at that point was a synthetic progestin, which actually is a pretty good progestin, although now we have some much better ones. But at that point, there were 2 doses, and everybody took Prempro. And everybody took Prempro to help your hair, your skin, your nails, your heart, your brain, your quality of life, your feeling of well-being. Okay? So, in the early 90s, they started this women's health initiative, which was a pretty incredible study. 80,000 women were enrolled over 10 years. And if you were to like put in PubMed or anything, Women's Health Initiative, there's a tremendous amount of study. I mean, this is a study that was looking to look at major health issues in postmenopausal women in general, not just about hormone replacement therapy. But they were studying, an arm of the study was looking at hormone replacement therapy. And what was interesting was that they started to notice that maybe there were some concerns about risk of cardiovascular disease and potential increased breast cancer. And so the researchers decided they were going to stop that particular arm of the study and start to do research on their results. Well, the beginning of the turn of the century was when the internet was kind of just starting, and somebody got hold of the fact that they stopped this study, and it kind of went viral. Well, once it got into the media, I can tell you as somebody brand new into practice, there was no way I was putting a person on Prempro, even if they needed it. But I was like, I don't know what to tell you. Like this, if you have an increased risk of breast cancer or heart disease, like I can't put you on that. And if you came to me on it, I was surely doing my best to try to get you off of it. And there was this whole thing that they really wanted us to use as small, you guys have probably heard, some of you have heard me say this, we try to use as little a bit as we can for a short amount of time, like just to get you through. Okay, not good. So, what happened, in some ways, I think this fact with the WHI study was a bit of a blessing, because what happened is it forced the researchers to go back and really look at the studies and reevaluate the statistics. And what they really found was that there were very minimal risks with regard to cardiovascular. One of the things that they noticed, and we'll talk about this a little bit later as well, but what we really found, the beauty of the WHI study was it helped us realize that starting hormones within the first 10 years after menopause is really your best time and your safest time, because if you remember what I talked about the cardiovascular risks a couple minutes ago, if you don't have estrogen in your heart cells and your blood cells, especially the ones in your heart, you're starting to lay down a tremendous amount of plaque and increase your risk. And so at that point, if after 10 years we now put you on hormones, and especially back then we were using oral hormones, significant increased risk of stroke and blood clots in that. And that was part of that WHI study. You know, they were studying postmenopausal, so these were 50 and above. I mean, they were starting women on hormones at 75 years old. Well, if they've never been on a hormone, that might be 25 years of plaque buildup. So yes, they had cardiovascular risks happening. The other really interesting thing was the breast cancer statistics that came out of that. Now, quick little gynecology lesson, I guess you should say. But when The way that our even just menstrual cycle works is that the first half of our cycle is called the follicular phase, and it's very estrogen dominant, and so it makes our lining all like fluffy and wants to receive, like if you were to get pregnant, it's a really lovely place for a fetus to implant, and it's all luscious and has all this blood flow, and if you don't get pregnant, then your progesterone level gets high, and I call progesterone the lawnmower. Many of you have probably heard this. So progesterone comes in and mows the lawn, and then when you have your period, it like washes the clippings away. So there's your cycle in a nutshell, essentially. So the point being that if you use estrogen alone, that you have a very high risk of developing uterine cancer. And so women who have their uteruses need to take progestin as well. You can't take estrogen without a progestin, or you really increase your risk of uterine cancer. So here's what was so fascinating in this WHI study. I feel like, at least what I've always learned, and I'm thinking a lot of you as well, is that estrogen is the culprit that causes breast cancer. Okay, so they looked at women who had had hysterectomies that took estrogen alone. No higher risk of breast cancer. Then they looked at women who took estrogen and progesterone together every day. Very slight increased risk of breast cancer, but not really statistically significant at all. And then they looked at women, and this is very old school, but they looked at women who took estrogen every day and then did what we call cyclic progesterone, where just from days 14 through 28, you take progesterone. And that's to help, and it makes sense to me when you think about it physiologically, because I just described to you what happens. You know, there's estrogen, and then there's progesterone, and then you get your period. So they were really trying to mimic that. That was the group of women who had a statistically significant increased risk of breast cancer. And I'll tell you something, I saw a patient yesterday who told me that she went to a practitioner locally, and got her labs checked. Okay, first, okay, you know, that person, I'm a little bit like, And then she was put on cyclic progesterone, like in 2024. I was like, no cyclic progesterone, please. So really important. I mean, some of this data, I don't think we ever really would have realized this if this whole study hadn't happened. And the other thing that happened was that since 2002, we now have, like, women who are here who raised your hand in your 60s. That means to me that you spent all of perimenopause not on any hormones. And so we really have this really great group that we can now look at of women going through this phase of life not on any hormones, and we can kind of see the differences that happen both with women on hormones and not. And now we're going to have probably, I think, the next 10 to 15 years where people are starting to go back on hormones at much safer doses and safer types of hormones, which we'll talk about, and then we'll have a lot more data to look at that as well. But just to me, there's so much that came out of it. The awareness of the risks and the benefits of hormone therapy. The other thing that came out of it was the realization that oral estrogen is pretty much very dangerous in terms of risk of venothrombolism, which is, your DVTs, your PEs, your strokes, and learning that transdermal estrogen, using those patches, well, not here, not on your breasts, okay? So down here, bikini line. But learning that the transdermal is significantly better for us than the oral. Also, we learned that we want to use estradiol, and we're going to talk about it on the next phase a little bit, that we're going to actually use what our body makes, and we have a lot more doses available. So the type of estrogen, the doses of estrogen, the way that we apply or take the estrogen, all of these beautiful things came out of that study. So let's see, the other thing here, what else does this say? Anything? I want to make sure, just so it says about the first 10 years of menopause. I already talked about that. Okay. All right, so let's go into treatment options. So first thing I want to say is that not everybody is able to take estrogen. And so there are definitely some people, and I am actually one of them myself, and which is also why I felt very strongly about finding other ways, but I carry a breast cancer gene called CHEK2, which is an estrogen receptor positive gene. And so me taking estrogen would sort of be like giving myself, the higher risk of breast cancer. So there's many reasons that women can't take estrogen. So number one, a personal history of breast cancer. You can't take estrogen for the rest of your life. Even a lot of women who have these estrogen-dominant breast cancer genes are not willing to take the risk. And even at this study, I asked the question, what if about somebody who has check 2? We need more data. Okay, well, until you get the data, I'm not taking estrogen. Like, as much as I think it would help and I would love it, I'm not personally willing to take that risk. But that's also part of the conversation that you have with your providers, depending on your own inherent risks. So, other reasons, migraine with aura. So migraine headaches alone are okay, but if you get that aura, that flashing light, or loss of your vision before a headache comes on, that would be a contraindication. And this is not just for hormonal therapy, but also like combined oral contraceptives. Like, you don't take the pill if you have any of these going on. And then a history of stroke or DVT or PE would be other reasons why a woman would not be able to take estrogen. So, those women aside, I'm going to talk about the estrogen therapies that we do have available and the timing and reasons that we use them. So, perimenopausally, so in that 35 to 50, average age of menopause, I'll put up there right now, is 51. So that's the average. So during the perimenopausal, I have a lot of women come in and they say, they're talking about this elevate in their mid-40s, and maybe they need contraceptive, maybe they don't. But a lot of times I tell women that, even if your husband has a vasectomy or I remove your tubes at the time of your C-section, there's a very good chance in your 40s you're going to need to revisit hormonal therapy for your either menstrual control or perimenopausal symptoms. And so we come back to these combined oral contraceptives. And again, we have so many more doses that we used to have, and we do much lower doses of the combined oral contraceptive now. And there's also a new one out called Nextstellis. I haven't used it yet, so if anybody wants to be my guinea pig and try Nextstellis, let me know. But this is an interesting one because it has estrotetrol, which is actually the estrogen that is predominant during pregnancy. But it seems to have some perimenopause promise, so I'm sort of interested to learn more about it and to try to use it. The other thing that people can do, which is really helpful in our 40s, is if you have either a progestin IUD, then using an estrogen patch with a progestin IUD is a really good way to help mitigate some of those symptoms that you're having and those really huge swings. Because even though the IUD is in there, that's very locally active. The IUDs are very systemic. Now, it's providing the protection of your uterus, though. If I were to give you you were to take an estradiol patch, and sometimes using that patch with that IUD is a really beautiful way to kind of sail through perimenopause and get yourself into menopause. Some people don't like the IUD. You can also use like just a mini pill, that progestin-only pill a lot of people use maybe while they were breastfeeding. So Micronor, or there's a new one called Slind, and one of those, again, with an estrogen patch is a really nice way to get through that perimenopausal years. So I'm going to take a half a second, and I'm going to devoid from what's happening on the slide, and I'm going to talk about bioidentical hormones. So one of the things I think that came out from this WHI issue in the 2000s is that people really started looking for, okay, we need something to help women in their symptoms. And, bioidentical hormones, I don't know, for our community sounds like amazing, right? Isn't that what all of us would want? Something that's bioidentical, that's natural, that's organic. I mean, it just sort of I don't know, fits the bill for most women in Flagstaff, if you ask me, And, but I'm going to be honest, it's the furthest thing from bioidentical that you can get. Bioidentical hormones are plant-based. We do not metabolize them well. We actually don't know how we metabolize them. And I have seen 5 uterine cancers in my 21 years of Flagstaff, and every single one has been on bioidentical hormones. And whether it was the pellets or the cream or oral pills. So again, if you go to that practitioner and they want to check your labs and give you bioidentical hormones, I again urge you to thank them for their time and walk away. Okay, so bioidentical hormones have proven to be quite dangerous. The American College of OBGYN came out 2 years ago with a very strong statement saying that it is not safe to use bioidentical hormones. And so anybody that is boarded with the American College of OBGYN at that point would be practicing malpractice to give them to you. So I know these are strong statements, but they need to be said. It's important to me that you guys hear this and know this. So, okay, so then and I'm going to talk about testosterone too, but I'm going to hold that for a couple minutes, okay? So I'll get there for people interested. Okay, so what do we have available for menopausal hormone therapy? And it's no longer called HRT, it's now called MHT, so menopausal hormone therapy. And so we have this estrogen therapy. Now, what we have now is bioidentical. Because what we have now in patch form, there is also pill and creams, but we have 17-beta estradiol. That is what your ovaries make. And that is what we replace. That is the safest. It is actually bioidentical. So we use these in patch forms. We have many different doses, probably about on the order of, I'd say, 4 to 6. And I know for myself, people who are working with me, I'm starting really low, and I'm having people come in and say, yeah, I feel a little bit better, but I kind of need a little bit more. I'm like, okay, let's go up. But so we have the patches. Now, remember, if you have your uterus, you can't just use a patch. You also have to take a pill, or maybe you have your IUD. But if you're going to take a pill, we do use something now called prometrium. And prometrium, I will say to the bioidentical world, it is bioidentical. It's yam-based. For whatever reason, prometrium has been studied. It's been used in Europe a lot longer than it's been used here, and it has seemed to withstand the test of safety, and it is much better tolerated than Provera. And so we tend to use prometrium now. So a lot of times we'll be talking about using a patch and prometrium. The beauty about prometrium is that it helps most women sleep. And so if you're one of the people who are having trouble sleeping, you know the estrogen patch is great because you no longer have the night sweat so much, and the prometrium really helps you stay asleep. So those are both really helpful. Non-hormonal options we have out there, the selective serotonin reuptake inhibitors, those SSRIs. So I said when you go to your doc and they say, why don't you take Zoloft or Prozac? Yeah, that can definitely help. It actually can really help the mood changes. And it can help hot flashes, although this isn't, that type of SSRI isn't what I'm talking about here. There's actually one in particular, paroxetine or Paxil, that when used, the normal dose of Paxil for like anxiety and depression is about 20 to 40 milligrams. And what we found, it's marketed as Brisdell or Brisdell. I just write it as paroxetine, generic, because it's cheaper. But 10 milligrams of paroxetine will actually help hot flashes. So it helps those vasomotor symptoms. So a woman who is struggling and can't take estrogen and is really struggling with hot flashes, that 10 milligrams of Paxil can be really helpful. It's not going to help their bones. It's not going to help their heart. It'll help the mood a little bit, I bet, some of that irritability, but it's not going to help some of the other things that estrogen will help in general. The other thing that happens with that dose of the paroxetine, that higher doses of SSRIs often make women anorgasmic. Now again, if you're like irritated with your husband and you're exhausted and you're dry, you could care less if you're having an orgasm or not. But the truth is that when you're feeling better, you want to be able to orgasm, and you don't want the medication that you're taking to try to help everything else to stop you from orgasming. So that seems like that would not be a good idea. And so the low dose of Paxil, this Brisdell, it doesn't seem to have that same effect. And so I just literally yesterday followed up with somebody who's like, the Paxil's changed my life, thank you, And she's somebody who can't take estrogen, so she was really struggling and looking to find something. So I'm really glad also personally to know that there's other things out there that can help other than hormones. Because it's no fun going through it. I don't know about you guys, but that's how I feel. Gabapentin, I'll be honest, I haven't used it very much personally. Gabapentin's used for a number of different things, a lot of times for like nerve pain and stuff, but there are a lot of great studies out there to say that it helps vasomotor symptoms as well. It's also not going to help a lot of the other things that estrogen does in terms of heart health and bone health and dementia, that kind of stuff. So just knowing that there's other things out there that can help is really good. So, okay, we're going to go to GSM again, one of my favorite topics. Hang on. Okay, so local treatments for GSM. So, now, a lot of times what I end up hearing and what you guys might be experiencing in, again, early 40s, mid 40s, is that you notice that at times sex is uncomfortable. And at times, sex is not. And you think, you know, oh, maybe I was just in a bad mood. Maybe I had 15 other things on my mind. Your husband thinks like, all right, maybe she's not that turned on by me, you know, like whatever it is. But you're like, this is happening. I don't really understand it because it kind of comes and then it goes. And what's going on? So one of the things that you'll notice is that right around ovulation and right before your period, you have these very natural dips in your estrogen levels. You will notice during those times that you feel like sex is more uncomfortable, or it's that time where I talked about earlier where you say, I feel like I have a yeast infection or a UTI or something, like right before I get my period. It's not an infection. Nothing is wrong with you. Your estrogen levels are dipping and you are feeling it in that vaginal tissue. And so using vaginal estrogen can be really helpful. Now in your 40s, and we'll talk about this at the end, or maybe I'll just say it now, in your 40s, you may not need, if it's only happening twice a month, you may not need to go on vaginal estrogen every day or every week yet. And so a lot of times that's where the lubricants, that's where vaginal lubricants come in. They can be really helpful. They're not treating anything. They're literally for comfort with intimacy. But a quick little tidbit about that is that you don't want water-based like KY and that kind of stuff gets really tacky. You want to think silicone. I talk a lot about coconut oil during that phase, not the white stuff that we cook with, but the carrier oil. So you go into Sprouts, our Sprouts, second aisle, turn to your left, all the way down, bottom shelf, clear bottle, coconut oil. Now, you kind of want the stuff that doesn't have an odor, because I don't know about you, but going to the Caribbean, every time you're going to have sex after one, may not be what you want. So get the stuff that doesn't smell. So the other quick tidbit with that is a little bit goes a long way. So if you use too much coconut oil, nobody's feeling anything, and you're kind of, and it's kind of messy. So a little bit of coconut oil here and there. Okay. So Sprouts is going to be like, what's the rush of the coconut oil? Sorry. Oh my gosh. And so just also going back to sort of that pregnancy condition too, this is also what happens when you're breastfeeding and at the end of pregnancy and when you're nursing, is that estrogen levels are low, and so that vaginal tissue is having that same response. And so again, this all kind of ties together. So all right, we talked about vaginal estrogen, we've talked about lubricants. I have not really used the ospemifene. It's pretty new, it's pretty expensive. Those of you who know me, I'm a little bit of a late adopter, and I really try to let's do generics, let's do the stuff that's been really well studied, that's been out there for a while before we're passing it out to everybody like candy. So I'll reserve a little bit, but it is nice to know that there is an oral medication. I will tell you, some women don't love the cream. It's messy. There are also an S-string, there are troches, there are tablets. There's lots of ways to get vaginal estrogen, not with the cream. It's just right now the cream is the cheapest, and it's also the easiest to start with to just make sure it makes a difference before you really commit to other modalities. The last thing I want to talk about here is this prosterone, and this is really interesting, vaginal DHEA. It's non-estrogen, and DHEA is a really interesting molecule because it's the precursor for both estrogen and testosterone. So I'm getting into the testosterone. So you're in the cells in our vagina, especially in those receptors, have both estrogen and testosterone receptors. And so it's actually a really nice modality to use. Again, if you can't use estrogen, it kind of gets it in a stage that's a little bit later that doesn't trigger any kind of risk regarding it. And then the other nice thing that I haven't mentioned yet when it comes to this vaginal estrogen treatment or this local treatment is that any kind of local treatment is not systemic. So they have done many studies where they have women who take vaginal estrogen. Usually it's twice a week. It used to be 3 times a week, and now it's really twice a week. And if you do serum levels of their estradiol, in a study, you can check labs, okay? So this is a study, not in general, but you will not see an elevation in a woman's estradiol level from just using vaginal estrogen. So they actually say breast cancer patients can use vaginal estrogen. I've had a couple take me up on it, most will not, and I don't blame them, because it's one thing to say it and it's another thing to live it. So, but I do think it's really important to make that distinction. And what's kind of crazy is that even up to a few years ago, women would go in with their prescription prescriptions, and they would be getting their estrogen patch or their pill and their progestin and then their vaginal estrogen, and the pharmacist would tell them, oh no, you don't need all that. You can either take the estrogen patch or pill or the vaginal, but you don't want both. That's too much. Okay, that's wrong. So you do want both. You need both often. So just know that there's also, one of the things they talked a lot about at this conference was that on the vaginal estrogen boxes, there is still black box warning about stroke and heart attack and breast cancer with vaginal estrogen. And there have been a multitude of studies that proves them wrong. And there's actually like a large force of people from the American College of OBGYN who are kind of lobbying with the FDA right now to try to get that black box warning off of vaginal estrogen, because it is not true. And it's scaring women from using it. And, you know, they go talk to their doctor, and I could tell them till I'm blue in the face in the office that it's not risky, and they go home and they open that box and they see that black box warning and they're like, I'm not using it. And that's a disservice, you know, that's a shame because it's not true. And now women are having so much discomfort. And again, it's not just with sex. It's like that feeling of discomfort and that you can't wipe and that you always feel like you have an infection. Like, that is no fun to be walking around day in and day out and feel like you have nothing that can help you. So okay, testosterone. Testosterone is, it's very controversial right now, and for people who follow stuff on social media, you will see many people, many practitioners talking about testosterone, and I will tell you, many of those people on Instagram, I follow the Menopause on Instagram. I love the name, right? But many of them were at this conference, and so they were hearing the same stuff I was hearing. And at this point, like everything else, we need more data, which I have a lot of respect for. We definitely need more data. But what we now know for sure is that systemic testosterone is not safe at all for a woman. There's really one indication at this point, and it's using testosterone cream mixed with an estradiol cream for a very specific vulvar dermatoses. That's the indication for testosterone. There are people out there getting pellets in their butt. There are people rubbing cream all over their thighs. And the truth is when you get testosterone, your libido is like, you know, you are like raring to go. Now, at the same time, male pattern baldness starts to set in, and facial hair starts to set in, and acne, and deepening of your voice, which is irreversible. And the other thing is that heart disease increases, because talk about that plaque formation with testosterone, much higher plaque formation than just with lack of estrogen. And then, I know you guys are gonna think this is probably a good thing, but I will try to urge you to agree with me that it's not, but clitoromegaly happens, which means enlargement of your clitoris. So the clitoris is analogous to the penis. So a clitoris in a female is the analogous structure to the penis in a male. So I know men want it bigger, better, all the time. That is not the case. It is not fun to walk around with a clitoris that is enlarged. I mean, I'm being serious, you laugh. But it's like crazy sensitive and really uncomfortable. And it's not reversible. So again, I urge you, if you go to that practitioner who wants to check labs, who wants to give you bioidentical hormones, and wants to shoot a testosterone pellet in your butt, run, don't walk, okay? You do not want to be seeing that practitioner, and I really, really do not want, I don't want any of my patients or anybody in my community taking this stuff, because it really is not safe. So, okay, I know I'm gonna have questions on that, but I'm gonna hold questions till the end. I have a couple more slides to get through, and then we'll do some questions, okay? All right, so, lifestyle, everybody good? All right, lifestyle modifications and their implication and their impact. So, one of the things that's interesting with lifestyle that we've learned is the critical role that it has with dealing with menopausal symptoms and overall health. Again, it's been interesting that we've had this 20 years where we have women who haven't been on hormones and have been between 40 and 60. And it's been really interesting to see their demographic and how their bodies have changed and the illnesses and the things that they're dealing with, because that wasn't what our grandmothers were dealing with, who were all on estrogen. And so we're having to really realize what's happening in our bodies. One of the things I think it's really important to recognize is that the average age of life expectancy for a female in the 70s was 68. Now it's 81. So that means we're spending almost half our life in menopause. Okay? That's big. It doesn't have to be awful, I promise. It really doesn't. It can be great. So, I don't know about you, but kind of like me in my 50s, I really want to figure out how to age gracefully and how I wanted to be able to move my body. I want to be able to travel. I want to be able to be on the floor with grandkids. I want to be able to lift grandkids. I want to be able to fall and catch myself. I don't want to worry about breaking a hip. I want to be strong. I want to be resilient. I want to be able to take care of myself. I don't want to be reliant on other people. This is what aging gracefully means. This is what aging gracefully involves. And I wish I could say that there would be a way to get around and do this without lifestyle, but there's not. So one of the things that happens, and again, we only know this because we have this now 20 years of women who weren't taking estrogen for so many years, is that we could study what was going on with them. And one of the things we've learned is that when cells are devoid of estrogen, they become insulin resistant. So the question is, what's insulin resistance? Everybody hears insulin and you just think diabetes and you're like, okay, well, I'm good. I don't have diabetes. But this is big, and it really affects everybody. So insulin resistance, essentially, what insulin does, I'll do a quick little teaching point here. So you eat, and your body breaks down your food, and it breaks it down into glucose. And then glucose is high in your bloodstream. Then your pancreas puts out insulin, and insulin's job is to get the blood glucose from your blood and bring it into your cells so that you can utilize it for energy. So what happens when you become insulin resistant is your cells get a little lazy, and they don't want to take that blood sugar from your bloodstream and get it into your cells. So it stays high in your bloodstream. So then now you're talking about pre-diabetes, PCOS, gestational diabetes, heart disease, even dementia. I don't know if anybody has heard, but over the last couple of years, they're starting to say that dementia is also known as type 3 diabetes. Okay? So this is no joke. And that's where the whole thing that I said earlier, you're eating the same and you're moving the same, and yet you're gaining weight. And then what happens, what do we do when we do that? We stop eating as much. We're like, oh, I'm gaining weight. I'm going to exercise more. I'm going to eat less. Well, now when you eat less, you're now telling your body to hang on to everything and do not lose 1 pound because you're starving and you need it. So you're acting against yourself. And then it gets you into this. I have people come in daily, weekly, just ready to pull their hair out, I don't know what to do. And so we really need to go back and start to really think about how we're living our lives, what we're doing, how we're moving, how we're eating, when we're eating, because all of these things are going to really help combat that insulin resistance. So just kind of going through, there's actually 3 main things on here. I'm going to talk about 3 more that are sort of, I call the minor lifestyle ones. And then I have one more big slide after that, and then we can chat. So in terms of nutrition, we want to talk about 2 things. We want to talk about when we eat and what we eat. And I'm a very strong proponent in talking about when we eat, first and foremost. So I don't love the name. So intermittent fasting or time-restricted eating, or at S&S we call it intentional fueling. So to put a positive spin on it. Because I think, for real though, there's so many people even sitting here that'd be like, have you ever tried intermittent fasting? Oh, I can't fast, I'm gonna pass out. I'm like, okay. let's talk about it. So what we've learned over time is that, we need these 7 to 9 hours of sleep every night to be able to, like we talked about how important sleep was earlier, and we really need that to regenerate, have our brains regenerate so we can wake up and we can have energy and we can concentrate. Well, what we've learned recently is that our gut needs a lot more time at rest than our brains do. And that there's a lot of healing that goes on. And really what gets healed is this, we become more insulin sensitive when we allow our guts to rest. And our mitochondria are stronger. We're the powerhouse of the cells. Everything sort of functions better metabolically when we give our guts more time to rest. And, it can be, people do different things, and I'm not here to tout that you have to do intermittent fasting, but I do think it can be very valuable to at least look at it. They say 85% of people will wake up in the morning and not actually be hungry. And I think listening to that is not a bad idea. I don't know about you guys, but I used to fight with my kids, especially Sam, to eat. We sort of made a deal at the end. I was like, okay, you just have to eat protein before you have exams. If you don't have an exam that day, I'm fine, do whatever you want. But it just felt important to me. But the truth was he wasn't hungry. And he knew his body. And there's actually a number of incredible things that happen in your brain when you are fasting for that long. So after an overnight fast, and now you're in the morning, you've actually blown through your glucose, you've blown through your stored glucose in your liver, your glycogen, and now you're starting to burn ketone bodies. Well, ketone bodies are where your fat is, so once you're burning ketone bodies, you're actually finally burning fat, but also ketone bodies are the preferred fuel for your brain. So especially people who feel like they suffer from brain fog, sometimes when they do this intermittent fasting, they'll actually feel way more clear in the morning because they're running on ketone bodies. So again, there's just a lot of food for thought in starting to think about narrowing that window. So the other thing, obviously, is we want to talk about what we're eating. So obviously calcium and vitamin D for our bone health. We want to do those omega fatty acids. For our heart, omega fatty acids are things like chia seeds and flax seeds and oily fish and walnuts and avocado, all those healthy fats. To me, really the mantra should be protein, healthy fats, and fiber. So the whole macros of being protein, fat, and carbohydrate, a cookie is a carbohydrate and a vegetable is a carbohydrate, so, you can use carbohydrate, but I don't know if it's gonna help you. So to me, you really wanna be focusing on this protein, healthy fats, and fiber in your diet. So, and then we already talked about the when as well as what. So I'm gonna move on a little bit to when about moving our bodies. So I do wanna put something out there very quickly to say that exercise is not about weight loss. It might have been when we were in our 20s. We could go for an extra run, or we could do, I don't know what was big when we were in our 20s, step classes or something. I don't know what it was. But the truth is exercise is for your heart health. Exercise is not to lose weight. What you put in your body and when you put it in your body will help you manage your weight. So in terms of exercise, we've come also a pretty long way. Both the American College of Lifestyle Medicine along with the American Medical Association, everybody agrees at this point that 150 minutes of moderate exercise is what you need a week to be heart healthy. So moderate exercise being where you can talk but not sing. So that might be a walk with a girlfriend, and 150 minutes is maybe 5 30-minute walks a week, or 3 50-minute walks a week, however you want to divide it, but that's really all you need. You don't need to go to the gym for 3 hours every day. And even if you do go to the gym and you're lifting weights, which is also hugely important in the strength and resistance, 2 sessions, 20 minutes. That's what you need. So it's doable. It's doable in our lives. It's doable with all we have going on. And it's very important that we get out there and we start moving our bodies, because actually HIIT workouts, weightlifting, walking, all of it improves your insulin sensitivity, and all of it minimizes that insulin resistance. So you just have to get it in there. You have to be moving. Sleep, coming back to sleep. So important that we sleep. And again, we can use hormones. That Prometrium is really going to help you sleep. A lot of people start start to use alcohol, start to use weed, take Benadryl, take Unisom, whatever it is. But the thing is that those have some lasting effects that aren't really good for us, whether it be the next day or years to come. And so trying to figure out some strategies that you can use to improve your sleep quality is really paramount. So, dimming your lights, and some people use red lights, and keeping your room a little bit cool. And there's lots of things that you can do to create this environment, but we really need to be focusing on sleep. Like I said earlier, it kind of begins and ends with sleep, okay? You can't get away from it. So that has to be one of the major things. The couple other minor, and they're not so minor because they're important, but they're just not part of the big three, but stress management is also some of the lifestyle stuff that we really want to be talking about. And to me, yoga and meditation kind of come in this vein. Learning how to breathe, learning how to manage our stress, especially when we're feeling crazy irritable and we want to lash out. I know people who say, like, I've never lost it in a meeting, and I lost it in a meeting, and I'm embarrassed, and it's, again, it's real. Like, it's not, and you're not a bad person, and you're not, there's nothing wrong with you. You're just having hormonal shifts that are, like, taking over your body like an alien. So, so the other thing I want to say about lifestyle that I think is really important, and if you were done slow and steady with me, you know this because it's kind of part of my usual mantra, but I'm not here to say that you're supposed to do all of this every day perfectly, 100%. Like, I mean, those of you who know me well, I mean, I don't have no chip November for a reason. Like, there's a reason I have no chip November. Like, I love potato chips. I mean, pretty much I love any potato. So, not so good for your insulin and your blood sugar, but I think figuring out moderation, figuring out balance. I kind of use this 80-20 mentality, and I think if 80% of the time you can, eat well and move your body and sleep well, please, 20% of the time, go to the girls' night and eat late, go have the birthday cake at your kid's birthday party. Like, I don't want anybody to feel that they can't live life, they can't go on vacation, they can't have fun. That's not what this is about. This is about figuring out that moderation, figuring out that balance where you feel better and you are doing better for your body metabolically, and you're also figuring out how to live life and have fun. So that feels very important for me to put out there. The last of the minor lifestyle modifications that I think are important, and I might get a little bit of pushback here, but it's avoidance of risky substances. So that, mostly what we talk about with that is tobacco and alcohol. So being in this community for 21 years, tobacco is not really a huge issue in our community, so I'm not really going to talk about it, but it is actually becoming more of an issue for younger kids. They're saying younger kids are smoking cigarettes again, which I'm just like, what? So I do think it's important to talk about, but with time, I'm not going to talk about that, but I am going to talk about alcohol. So here's the thing with alcohol. Alcohol, unfortunately, even though we all use it when we're perimenopausal because we need something to help us get through the evening with our families, the problem with it is, immediately is that it exacerbates our menopausal symptoms. It's going to make your hot flashes way worse, actually, and your mood swings, and you're feeling irritable. And it actually increases your osteoporosis risk because it inhibits your absorption of calcium. And it affects your quality of sleep. Now, I know many of you feel like, oh, no. I have my nightcap. I go to sleep just fine. Well, I would urge you, if you wear a little watch or something, my guess is that you are falling asleep just fine, and then you're waking up to go to the bathroom a couple times, but you're probably not getting very much REM sleep. And REM sleep is really important for us to get. We need all phases of our sleep in order to be well rested and to really regenerate. And so if you are sleeping night after night, after drinking 2 or 3 cocktails a night, you're not getting that sleep that you need. So it definitely adds to the midsection weight gain as well. I think for a couple reasons. It's based in sugar. Also, a lot of the fancy drinks, you have extra sugar, but you also lose a lot of your inhibition. So you have a couple cocktails, and then I'm like, oh, there's the potato chips. Look at that. They just showed up. So, and now you're eating later, and you're eating junk, and you just drank, and it just sort of, it just snowballs on itself. So it definitely, alcohol contributes to high blood pressure, high blood sugar, increased cholesterol. And the one thing that I couldn't believe, and this really came to me, and the reason I'm even talking about it is almost every single lecture at that National Menopause Society, every single day of lectures, I should say, and it was a week-long conference, my colleague and I, who I went with, would go back to our room and be like, alcohol. Like, everybody talked about alcohol. I couldn't believe it. And one of the kind of scarier things to me is that there's a lot of studies out there showing the link between alcohol and breast cancer now. And that's no joke. So, we're doing all this stuff, and I don't want to take estrogen because my breast cancer, well, you're having a bunch of cocktails, so, you choose. But, you just have to know, though. And I think that that's the thing, is that before I went to that conference, even though I look at PubMed, I do literature sources all the time, I would not have told you that alcohol was linked to breast cancer before that conference. So that was pretty huge. So essentially, again, I'm not telling you that you can't drink alcohol. I haven't even talked about the blue zones, but many of you who, I don't know, do you guys know about the blue zones, people? Yeah, so these are places in the world. There's 5 or 6 of them that are designated, many more, where people naturally live to be 100. They're centurions, and they really look at lifestyle. The one thing I didn't talk about with lifestyle, I kind of forgot, was connection, which is like what we're all here for. So that's also very important in our lifestyle, that we need to be connecting with people, whether it be family, whether it be friends, whether it be our community, but connection is really huge in terms of longevity. And so in these blue zones, it's pretty interesting. In both Sardinia and Okinawa especially, they convene every night for a cocktail. I know. So one of the things that we've noticed is that when you talk about alcohol use disorder, is that we've found that if people are having 7 drinks or less a week, that you really don't have significant risk of symptoms, or risk of things coming from alcohol, risk of developing all the things we talked about above. So, and that's what they do in the blue zones. And these people are living into their hundreds. So again, I'm not saying not to drink alcohol, but I'm saying to be mindful and to know what its risks are and to know where the level of moderation is that's going to keep you healthy and keep you safe and keep you sane. Right? So, okay, a couple things you can do. So, making sure you're drinking 1 drink a night or less. And if you drink more on the weekend, then you wouldn't drink as much during the week. So you want to kind of figure out that balance for yourself. Sometimes just double fisting it, not with 2 drinks, but 1 with water and 1 with alcohol. So, have your alcoholic drink and then down some water if you're going to have a second one for that night. And because that's really going to help when you go to sleep. It's going to help minimize your vasomotor symptoms and those night sweats if you can actually drink some water and get hydrated. And the other thing this is really interesting because I've actually recently had 2 people who, one was slow and steady and one at Flagstaff OBGYN. I was talking to 2 different women in the last month about hormone replacement therapy or menopausal hormone therapy, and both of them said to me, look, I want to try to see how I feel off alcohol before I go on hormones. And I was like, okay. After 3 weeks, both of them came back to me and said, most of my menopausal symptoms are gone. It was impressive. So there's food for thought there. So, okay. We're going to do some just key points quickly as I wrap up here, and then I can't wait to talk to you all. Okay, 100% of women go through perimenopause and menopause, and there is a myriad of ways. I didn't even say this earlier, but you are not going to go through it the way that your neighbor goes through it at all, or your best friend. You might go through it the way that your mom and your sister did. There is a genetic connection to the way that we really do most things in our female reproductive system, how we give birth, how we have success with breastfeeding, how our menstrual cycles go, and then how we go through perimenopause and menopause. Very genetic, but it is very different for each and every individual. So that's really important to know. We have to start having the conversation. We have to normalize the conversation. We have to be talking about this. It cannot be something that we're scared of, that we feel like people are going to judge us, that there's shame involved, or that there's something actually wrong with us. There is nothing wrong with me, with any of you. We are just literally going through this phase of life that we have to learn about and we have to talk about. We've talked about with providers, coworkers, family members, kids, friends, in groups like this. This is really important. I wanted to make sure that everybody understood that impact of the WHI study and where we are with hormones, where we were and where we've come. I want people to know that there are safe and available treatment options out there, both hormonal and non-hormonal, for people who can tolerate or not tolerate either of those. It's important to me that you guys recognize the importance of lifestyle habits and their impact on minimizing your menopausal symptoms. Chronic disease, osteoporosis, cancer. And I think the thing with the lifestyle that really holds true is that, and this is where slow and steady comes from me, is that it just becomes accountability. You know, it's so easy to say, oh, you just eat well and sleep well and move your body. And it's so much harder to do it, like on the daily. It's hard to do it. It's hard for me. I know it's hard for everybody. So sometimes you go through weeks that things are crazy and I can't even barely get a walk in sometimes, you know. So, but you want to have your posse, you want to have your group, you want to have the people, whoever you can reach out to, me, friends, family, but find little groups, make yourselves accountable to each other. This is really important. And band together, because you feel better once you do it. You can't help but feel better. I can't think of anybody, unless you hike that we did a couple weeks ago, that would do any kind of exercise and not regret it, okay? So, but you almost always feel better. Almost always feel better after you exercise. So, okay, the biggest thing really, you are not crazy. You are not alone. There you have it. So I do want to open up the floor. I want people to be a little bit, I want people to start thinking, the reason I'm really doing this and starting this conversation today is that I would like this to be a place that we go. This is a launching pad, and where do we go from here? So on your, in the back of your handout, you'll have a QR code. There's this survey that I would really love if people wouldn't take a few minutes. Please pull out your phone while I'm talking. We're not at the dinner table. You can pull out your phone. So, and please fill out the survey. There's options in there. We can do more talks on specific subjects. We can do a menopausal health fair. We can do menopausal support groups. There's actually a documentary that came out. I don't know if anybody's heard of it recently. It's a 45-minute documentary called The M Factor, and I would love, love, love to try to get it. I've been talking, have my feelers out to people at the Orpheum to see if we can't get that and screen it at the Orpheum, because I think that would be a really awesome thing to do in our community. So, so please fill this out, and you guys have most of that. There's also, if people are interested in slow and steady and you're not already on my email list or get my newsletter, this would be the QR code to do that. And then I'd like to open the floor. And like I said at the beginning, I'm open to questions, and I'm also open to just comments or conversation pieces that people want to have. So, yes. Do you want me to bring you a mic, or you want to try to?
I can try.
Okay.
So on one of the first slides, when you were describing symptoms of perimenopause and menopause, one thing, I guess my question is, when do those things go away? Like, so... Yes, great question. I mean, I'm in the menopause camp now. Okay. And so I feel like some of those were there, and I'm just wondering about, like, you had both of them up there, but what happens?
It's such a good question. So in terms of the vasomotor symptoms, kind of the things that you really notice, like right off the bat, those hot flashes and the night sweats, people will say that those can last anywhere from 2 to 5 years. I will tell you, in my history, they probably can last upwards of 10 to 15 years. So some women are definitely in their mid to late 60s and still dealing with vasomotor symptoms. And it really depends. Some of the symptoms, I think what you're asking is if you weren't to take anything or do anything, how long would they last? So it's very genetic. It's different for everybody. Probably on the order of 2 to 15 years, I would say, depending on the woman. I know.
So I'm on the new menopausal, not HRT, but
MHT?
MHT.
Yes.
How will that impact my process of perimenopause and menopause? Like, am I going to have to carry forever? Like how will this
yeah, good
change
question.
my progression of how things are going?
Yeah, it depends on the dosages that you take, but once a woman once the ovaries are really stopping their production of estrogen, and you get some estrogen from your adrenal glands also, and you also get estrogen in your adipose tissue, so heavier women tend to be more estrogenized because you convert estrogen in your fat cells. So again, it's a little bit different for everybody. I would tell you if you're taking MHT that you really probably, if you have gone through menopause and then you start MHT, you probably shouldn't have bleeding for any more than 4 to 6 months. If you have bleeding on MHT for more than 4 to 6 months after you've been through menopause, we need to do an ultrasound and we need to evaluate that. And we need to talk about dosage. So, but it really should mitigate a lot of your symptoms. And so in terms of what you feel like you're going through, it should help almost all of it. Yeah. Yeah.
I have a couple of questions. One is, what height did you do?
We did the salt trail.
Oh, okay.
Yes. No. I'm actually kidding because it was amazing to get down there, but the getting down there and the getting back, no bueno. I literally had a temper tantrum on there. Literally. It's a little embarrassing, but it's true. Okay. Yeah. Second question.
Would you ever use like progesterone without estrogen?
You can. Yeah, you can.
Okay.
I have to be honest, from the research that I've done, I will not be surprised if progesterone is actually more of the culprit for breast cancer than estrogen.
Okay.
So, to me, you use as little amount of progesterone as you can use to protect your uterine lining if you're taking estrogen, and that's it.
Okay.
Yeah.
And then third, I was just a little confused because you had strong opinions about bioidentical hormones.
Yeah.
But then you said some of the things that you prescribe are actually bioidentical.
This prometrium, the progestin that we use these days, it did come out of that bioidentical era, but it's withstood the test of research.
And are bioidentical hormones FDA?
No.
Okay.
Prometrium is now, but no, none of the bioidentical estrogens are FDA approved or recommended by American College of OBGYN at all. Yeah. Yeah.
What is the risk of not taking any hormones? Just letting things happen naturally?
Yeah, the risk is, I'm someone that I don't take hormones because of my breast cancer risk. So that's where I sort of did the deep dive into the lifestyle stuff because I felt like I needed something because I was pretty miserable. And so I think it's very individualized, If people want to sort of power through it, by all means, power through it. I do think there's something to be said about the insulin resistance, though, what we've learned. And so I worry that if women don't do anything lifestyle or hormones, that we really are increasing our risks of obesity and prediabetes and type 2 diabetes and heart disease. And so that to me, that's the risk involved if you do nothing.
Sure. Well, when you said that when estrogen receptors in your heart,
In the blood cells?
made me think, well, maybe you do have to do something.
Yeah, not necessarily,
Okay.
Yeah.
To follow up on that one,
Yeah.
is bone density another risk if you're not taking hormones?
100% bone density is, yeah. And I talk about things like using a weighted vest. If you're not going to take estrogen, or even if you are osteopenic and you're in your 50s or 60s, you should be walking 3 times a week for 30 minutes with a weighted vest, 10% of your body weight. That's going to help your bone density. Yes. There was a question here.
So, if you cannot take estrogen,
Yeah.
you're recommending for the rage, the absolute rage.
The absolute rage? Yes.
I'm starting to think that the Perrins,
Yeah.
it's just none of
You might be onto something. Maybe they're just menopausal women who are not taking any shit anymore. No doubt. Absolutely. I love that. Gives care of that shit. Yeah.
But so if you can't take estrogen, then and you can take the Paxil, you said, the 10
Yeah.
milligrams. correct?
Yeah.
Okay, and then also you would incorporate the Pax. Progesterone for the
Progesterone vaginally, yes.
Okay.
Yeah,
And
that would be a great
But anything
combination.
else is just lifestyle. That's
And then
for
lifestyle.
SLL, we can't take the estrogen.
Absolutely, right. So low dose Paxil, 10 milligrams of Paxil for your hot flashes, and lifestyle modifications and progesterone for your vaginal symptoms. Yeah,
Okay.
that would be a great.
And then also, I notice when I work out, my muscles are a different kind of sore. Is that normal with the perimenopausal stuff? It's like, it's not, it's just like, it hurts way worse.
Well, I will tell you, like, no pain, no gain. Like, you want to be injuring your muscles to the point where they are sore because you are doing a darn bit of good by doing that. So embrace it.
Okay.
Embrace it. Keep at it. Yeah.
So if we're in menopause
Yes.
for the rest of our life,
Yes.
and you are on HRT,
MHT.
MHT, that's hormonal.
Yeah.
How do you know when to stop it? And sort of, so our estrogen dips, and then are we just raging the rest of our lives?
That's such a good question. I love it. Yeah, so at some point you sort of find a new homeostasis. And so you're not necessarily feeling, part of feeling the rage and part of feeling it is that you've had these swings. And so as you sort of go to this like very slow decline, at some point you sort of have like a new homeostasis. But that's a very good question, and there's not, we're just starting to figure that out, but you do not have to stop your hormones at age 60 anymore. At all. You can stay. We don't, Sue, we don't have an age. You can stay on it, honey. Just stay on it. Yeah. Yes.
First of all, I feel like teary thinking about how grateful I am that you're doing that. So first of all, thank you. And I'm so grateful that you're doing that. How do you recommend people find a practitioner?
Oh, good. Thank you.
That will not do all the things.
That's a very good question. So number one, I will be doing a CME, so continuing medical education, through the hospital for primary care practitioners, anybody, any allied care, any practitioner in Flagstaff that wants to come. I will do a talk for them to educate them on what the latest and greatest and safest are to be helping our community. So that's number one. The other thing, and it's actually on the handout, but thank you so much for bringing this up because I skipped over it. But there's an online medical practice called MIDI, M-I-D-I, and they do hormone treatment. They prescribe MHT over the phone, and I vouch for them. I know a number of them. I spent a lot of time with them at that Menopause Society meeting, and I know a number of them personally who are involved in the company, and they're legit. They are practitioners who they will go through risks, they will go through your individualized issues, and they will help you find the right regimen. And the nice thing about that, Kristen, is you can see a practitioner at MIDI, and you can make an appointment with someone in town. And by the time you see them at that appointment, hopefully they'll have come to the CME and you'll be good. So, but you can see someone in town and you can already be on those hormones from MIDI. They'll come in the mail. And then you can work with your local practitioner about adjusting them if you need to or making whatever changes. So that's a great question. Thanks so much for bringing that up. Yeah.
So I'm also wondering how you determine what kind of dosages are best for you with the hormone treatment, because you say that it's not useful to check your labs, but how do you know you're having too much or too little?
Yeah.
Without checking.
I am listening to you. That's how I know. Yeah, one woman I had last week was like, I feel really great, but I'm really nauseous all the time. I think I need to come down. And another person's like, I feel really great, but I still am raging. I need to go up, kind of thing. So it really, and it's a little bit, and I'm honest with people. I'm like, look, this is trial and error, and I'm starting low. Like again, I'm a late adopter, so I'm going to start really low, and I'm going to go up slowly. And we do it, first we talk about it every 3 months, but I think really meeting with people every 4 to 6 weeks when you're trying to do adjustments is probably a reasonable time frame.
And the second question here is, you said no to testosterone, but even like super low dosage, no?
There is really, the data is not there to support it at this point. Yeah, it might be. I think there's a lot of studies happening right now on testosterone, and it really might be. I mean, people who give arguments for testosterone, it's hard to ignore some of them, to be honest. I'm really just looking at evidence. So evidence-based medicine right now, yeah. Yeah?
Just to back on that, so Prometrium is
Yam-based.
estrogen?
Prometrium is the progestin. That's the progestin that's yam-based.
Is there also testosterone that you can get that's made from a yam-based?
I don't know. You're the dietitian. You should tell me.
Well, and it's an injection, so I wouldn't get it.
Right.
Be in my
I don't know if testosterone that's yam-based. I've never heard that, but maybe.
One of my girlfriends said she started taking it, so I didn't know if that was the same thing, so it's something different.
It must be something different than, yeah. Prometrium is progestin, and it's yam-based. So that's the one that I was saying is bioidentical, even though we say no bioidenticals, but the prometrium really has been the one, that bioidentical hormone that is safe.
I mean, I'll ask her, maybe she's...
Yeah. Ask her, yeah. Anything else? Yes, yeah.
Also, I'm with Medi Health.
Yeah.
I've been with them for 15, 16 months.
Okay.
Game changer.
Game changer.
Absolutely.
So as a patient, you've been with them?
Yes.
Yes, awesome, okay.
My NP was organic. Actually, it was funny because I saw somebody up here who was going to give me testosterone, estrogen, and progesterone at one time, and I was like, no, I'm good. And I never went back to that person.
Good.
And I found Minnie's.
Good, I'm glad you found Biddy.
But I have questions too.
Yes.
So I'm at like 10 months. 10 months. If I
Without a period?
Yes.
It doesn't count if you're on hormones though necessarily, but go
Okay,
ahead.
so that was my question.
Yeah.
Does that matter? One, does that matter? And two, when I get 12 months, what happens?
You're in menopause! That's it!
But it doesn't matter when you're, so I have to go off hormones and then be 12 months ago.
No, I mean technically the truth is that past the age of 55 or 56, like you're in menopause.
Okay, so when 12 months rolls around, you're soon.
Yeah.
Can I throw a party?
Go party! Yeah, welcome. Yes. Girl menopause party. I love it. I have one group of women who are holding, what do they call it? God, I wish she was here, Christine. Menopause and masturbation parties. I'm like, all right, that's a good one. Cool. What else? Yeah.
If you want to go to the party,
Yes.
what do you suggest? To boost,
I think you get really dressed up all fancy.
so boost the libido.
To boost the libido?
Yeah.
So I do, yeah. I do. Well, I think that's a good question. You know, you do all of it, I think, to some extent. So I think vaginally, I think you need to have that comfort vaginally because there's no way anybody wants to go to the party if it's painful. Again, like you don't even want to go in the door. If you can't get through the door, you're not going. So if that vaginal tissue is really atrophic and non-elastic and not luscious and wanting, and then, yeah, not going to happen. So I think sometimes you can just start with vaginal. And then just in your mind, even, if you know it's not going to be painful, you're a little more apt to want to do it. And then I think a lot of the lifestyle stuff, as well as the MHT. But the lifestyle stuff also, you know, stress management and meditation and getting out there for walks and eating well, that makes you feel better. And when you feel better, you feel sexier, you feel better about your body, your libido naturally increases. So when I say all of it, I mean all of it. Yeah. Yeah.
So if you are doing the hormone therapy,
Yeah.
is that going to stabilize your hormones and also improve the menstrual cycle? Like myself, I had a period of like 14 to 20 days.
Yeah.
I'm tired of that.
I'm so sorry. Yeah, it should stabilize. Yes.
Normal?
It should stabilize. Yeah, right. It depends on how old you are and what you're doing, but absolutely it should stabilize it. Yeah. For sure. Yeah.
If you've had a uterine ablation or for some reason you're not having a period,
Yeah.
how do you know when you've hit menopause?
You might. Yeah. As you get to 55, you hit menopause. Yeah. Right. Exactly. Yeah. It really is age. I mean symptoms, but age. Yeah.
Is it different for PCOS?
Good question, because women with PCOS and women who have had a history of gestational diabetes are already inherently insulin resistant. say that's really what PCOS is, really now a syndrome of metabolism. Sometimes it's of elevated male hormones, but more times than not, it really has to do with your metabolism. So people with PCOS or a history of gestational diabetes, to me, need to focus on the lifestyle stuff even more. But no, it doesn't change the timing or the way that you go through perimenopause or menopause. That's just genetic, which those can be as well. But in order to help with the symptoms, probably bringing in that lifestyle stuff is going to make a big difference for those women. Yeah?
When you're talking about intermittent fasting, is there like a minimum and maximum time that?
It's so different. You know, there's so many things out there. I'm a really big Jason Fung fan, F-U-N-G. He's a nephrologist who wrote maybe one of the most boring books on the planet called The Obesity Code. I mean, if you're going to buy it, it's $11 and then get the Harlequin Romance to read with it, because otherwise you won't get through it. But, you know, he really talks about the metabolism and why the whole intermittent fasting makes a lot of sense. And there's also, what's the one you guys do? What's her, what is it? Fast Like a Woman?
Yeah, Fast Like a Girl.
Fast Like a Girl. So, and that's one that actually more follows your menstrual cycle, and so you do a different number of hours based on where you are in your menstrual cycle. And, you know, to me, what I found with intermittent fasting is you have to figure out what works for you. And there's so many different ways to do it. Usually people think at least 12 hours, and if you can get to the 14 or 16 hours of fasting, that's really going to make a big difference for you with that insulin resistance. But 12 at the very least. Yeah?
What do you think about like coffee and your creamer? Because they say like under 50 calories.
Under 50 calories, yeah, you know, right. So under 50 calories is still considered. So I love my little vanilla Kaifia almond creamer. So, you know, a little bit in there. The truth is also, if you're doing something every day, regardless if it's 52 calories or 49, you know, your body's going to get used to it. And so I think, yeah, a little bit of creamer in your coffee, ideally not with much added sugars. You know, and cream itself doesn't have actually added sugars in it. But you just want to try to stay under 50 calories during your fasting. Now, your body recognizes you as still fasting if you're ingesting 50 calories or less, is what we're getting at. So that's a good question. Yes? I got the rager.
Well, I just have one more. When you mentioned
if I don't let her talk, she's going to crazy.
Because you had mentioned that some practitioners will give you the progesterone to take, you know, 15 days after.
Yeah.
I'm doing that currently.
No. Yeah.
And I'm not estrogen.
Oh, you're just doing the progestin.
I'm just doing that. So what do you recommend? Because I do feel like it helps you sleep better, all that.
I just say you take it every day.
Just take it every day. So the issue is the stop and
yes, it's the cyclic part of it that's bumping your risk of breast cancer.
Okay, good to know. Thank you.
Every day. And you'll still menstruate through that if you're menstruating.
Okay.
Yeah. But you'll feel better and you'll sleep better. Yeah, Shan? Oh, yeah?
I think somebody had a question right over.
Okay. Yes?
Yeah, it was you.
So would you ever do the prometrium and estrogen for perimenopause?
Yes. Yeah, you can. You can later though, for like more in your mid to late 40s. Early 40s, I would stick more with those combined oral contraceptives or an IUD and a patch. But you could definitely start. I've definitely started women more recently, 47, 48, on the prometrium and a patch.
Or just with progesterone like she does.
Yeah, you can. I don't love progesterone by itself, as I told you. So yeah. Yeah, but sure. Yeah.
I just have a random question.
Okay.
You had brought up, you know, like the hair thinning and that kind of thing.
Yeah.
So what I have found, I always had bone straight hair, and now I'm curly. So has anybody else done that?
Earlier. Yeah.
Yeah, I'm like, what is happening?
Yeah, it's just changes in your hair follicles based on changes in your hormonal levels. Okay. No doubt.
Just checking.
No, I'm not crazy. Yeah, you are. Hey, you are not crazy, and you are not alone. That is our mantra. You are not crazy, and you are not alone. All right. Yes.
You talked about alcohol. What about marijuana?
Yeah, good question. It came up at that conference. Definitely what they're saying about THC, a lot of people, you know, what they found is people are doing these gummies. and that they're taking like really ridiculously high doses, like 40, 60 milligrams, like crazy doses. And it also really significantly affects your sleep, is what they're finding, and your ability with concentration the next day, especially at those high doses. So, yeah.
It'll make me fall asleep, but if I wake up,
You're gone. Yeah, right. Now your anxiety is high. Yeah, I know. I just, yeah, I wish there was a magic pill I could take. Yeah. Yeah, anything else?
What kind of gummy?
Hey, I got some in my car. I'll give you some. THC. Yeah, THC gummies. Yeah. And CBD. The one thing I'll tell you with CBD is that CBD needs THC to be potentiated. So if you're taking CBD stuff alone and you feel like it's making a difference, every single study on placebos will show that placebos have a positive effect in 30%. So you can take your CBD gummy, it might be helping you sleep, but you need the THC to actually get the effect of the CBD. Yeah. Yeah. Yes. Yes, I did. In the derm section, I probably didn't say dryness, but yes, dry skin, dry hair, dry nails. Again, this is like some of the reason why, everybody in the 50s was on hormones, and, their hair and skin were beautiful, and they were luscious, and so yeah, that's real. We have a friend that's a derm PA that I wish was here tonight, because she probably could have answered these questions a little bit better than me, but people just say that they slather on the lotions and that it doesn't make a darn bit of difference. So I would definitely talk about coconut oil, again, sprouts, second aisle, bottom shelf, you get it, right? But then also estrogen. Estrogen probably, in way more than progestin, but estrogen is going to be the thing that really helps your skin. Yeah. Yes.
Is there truth in, with the estradiol patches, taking a hot bath or a hot tub or something afterwards, getting a hormonal dump?
That's a good question, Mark. I'd have to look that up. Have you experienced that?
I have not read about it, and it concerns me because I love me a hot bath.
I love me my hot tub, is what I love. So, yeah. I will have to look that up. I don't know the answer to that, to be totally honest. Yeah, I'll let you know. Yeah.
So I'm taking a low dose estrogen and progesterone birth control pill. And I don't know if she asked kind of a similar question, but is this something I should be consistently taking, or taking a break after 3 weeks, 21 days, or?
Are you taking it continuously? Or do you,
yes.
You take it for 3 weeks and then get a period?
I would take it for 3 months or 72
Yeah, that's fine.
72 days. Should I be taking a break at all, or should I just
a lot of times, we used to say that you want to do 12 weeks and have about 4 periods a year. We do know now that you can go on it continuously, and because it's medically, the period that you get is not natural. It's
I'm not really getting that.
Right.
So I don't even know if I'm menopausal or not.
Exactly. Based on your symptoms. Yeah. So I would say you can take it every day. You don't need to take a break. A lot of times if women are doing that and they start spotting, what I'll tell you is that you have to stop the pill for a week or you'll just keep spotting. So once your body will let you know, like, I need to shed a lining here. So if you start spotting and you're doing continuous oral contraceptive, you want to stop for a week and then you want to restart. If you're using it for contraception, you don't want to stop for more than a week or else you're going to be knocked up and seeing me for a different reason. Yeah, so only for a week and then you would restart. Yeah.
So with the patches, how does that work? Are you walking around with a patch every day, all day, or is it you put a patch on?
Good question.
Hours?
Yeah. Oh, that's a great question. So the patches, you're wearing them 24/7. We usually recommend changing twice a week, at least the people that I found. There are weekly ones that you can change, but a lot of times people say they start to come off, or you're in the hot tub, or you sweat, or you work out, and they start to peel off. So people really like the twice weekly. I like the twice weekly. Also, if you're doing vaginal estrogen, you just sort of do those like Monday, Thursday, you change your patch and use your estrogen, and Tuesday, Friday, like you pick your time frame. But the patches are little, and you put them on like your bikini line, and I'll tell you kind of change the spot, so you don't always put it on the same spot, and then that black stuff that gets on your skin. Right here's the trick though, the black, like you get like sometimes a little ring, or acetone. Nail polish remover gets that stuff off right away. So otherwise you're like picking at it, now you have a rash and you're all irritated and you hate the estrogen patch. And so acetone gets it off and then you're just moving it, but you're wearing it 24/7.
What is the alternative to a patch, or is it, that is it?
There are some new creams that are out there, and I have some people who can't tolerate a patch, and I've just started to use something called Divigel, and it's an estrogen cream, it's daily, and I just literally started using this, so I don't know yet, but you don't want to do the pill. You don't want to do estradiol in a pill form.
If you want to do the patch, I'll show you.
Me too.
Let's see it.
Too far down my butt.
Very tiny.
It's little.
What percentage of you have already seen my ones?
It is like that.
Did you see my black ones?
Yes. All right, Greta had a question. Where's Greta?
So just in general, vaginal, I apologize, I forgot the second word, because, yeah, all that.
Vaginal dryness?
Estrogen. Would
Yeah.
that have any impact on your partner?
No, good question. Yeah, no, a lot of people have asked that. No, they're not going to get, like, their penis isn't going to add estrogen on it. Yeah, you're using it twice a week. Yeah.
I want to follow up on Chandra's comment. If you're taking a low dose birth control pill and
Yeah.
it's working for you, like
Yeah.
you just stay on that for.
Yes, and really until this past year, I had a lot of you on to like 53, 54. So we feel like 54 is probably the latest time we want to use a combined oral contraceptive. But I would probably start to urge women, if we could get off of that in the late 40s, early 50s and switch over to the estrogen patch and the prometrium, it's a lot less hormone. And you still get your bang for your buck where you feel better, but you don't have the risks at the higher hormone levels.
Which the negative would be the progesterone?
Well, the negative, I think, with really high hormone levels, just when you're taking the pill because you're doing it orally, is blood clots as you get older. Yeah, that's your biggest risk.
So remind us again the age where we should probably get off of the birth control and go on to.
Probably right around 50, like or late 40s, early 50s.
Okay.
Yes. Yes.
Two questions, one comment. The dryness over there, dry Flagstaff too.
Right, very true. Very true.
And,
Flagstaff.
And then, how long for the intermittent fasting?
Well, it's really different for everybody. I'm kind of a 8-16 split, so 8 hours of an eating window and 16 hours of fasting. So maybe from 10 to 6 is my eating window, then I'm not eating from 6 p.m. till 10 a.m. the next morning. Mine is my tea with my little cream. Yes.
And then, which labs are you talking about?
Oh, people want their estrogen and their progesterone levels checked.
Oh, okay. Because they're just like this.
They are just like that. Yeah, very not valuable. Yeah.
What percentage of women do you think choose to not do any sort of therapy? Because I feel like I'm leaning toward that camp, although Christy just gave me some estrogen.
Okay.
Thank God we'll get that oral. But to not do any of the estrogen stuff throughout the rest of my life, is that a poor choice? You said it was individual, but
It is.
am I missing the boat? Because I feel like that's definitely wrong.
I think that's where we're sitting right now. I think your question really nails like where our generation is sitting. Because again, remember the women who were in their 40s through 60 in the last 20 years after the WHI study, they hadn't been using. And so you probably need to ask them how they felt. But I think that I think part of it is trying to turn a really large ship around, which happens very slowly. And so I think getting education out there, letting people know what the studies are showing, letting them know the risk and the benefit profile, and then individually. So that some people really go, you know what, the truth is that I feel like I can deal with this. And yeah.
So I'm not shooting myself in the foot.
Not necessarily. I think if you have a strong family history of insulin resistance, that might be something to think about, or you really need to beef up the lifestyle stuff. So yeah, I think it's very individual. Yeah. Yeah.
So the hormone therapy would help with the insulin resistance issue?
Yes, estrogen, giving yourself back estrogen, because that's one of the things that your cells become more insulin resistant when they become hypoestrogenic. And that's that time frame in your mid-40s where you're doing the same thing you've been doing, and all of a sudden you're like, what is happening? Yeah.
You said you did some gene testing to determine if you have that breast cancer
Yes.
gene. Do you recommend that? And
I do, actually. Thank you for bringing that up. Yeah, you know, you guys, there's a really great, Sheila's not here, but there was actually one of the pediatricians a couple years ago came to me and told me about the WISDOM study, WISDOM, all capitals. It's out of UCSF, and they do free genetic testing. And I got tested years ago, like maybe 3 or 4 years ago now, but at this conference, they were there. And they're looking for women to join the study, and not necessarily women. They first were looking for women with breast cancer family histories. Now they're looking for women without. So, because I think they are really, this very comprehensive testing. So they're great. They do this battery of tests. And did you get your results back?
Not yet.
Okay. And so they give you this really great pro forma when you get all your results back, and then you talk with a genetic counselor, and then they make screening recommendations. And they're pretty spot on.
And it's free?
It's free. Wisdom. Yeah. Go online. Yeah.
so without hormone treatment, like incontinence is a thing that's happening. And does it go away? Or will
Well,
that get better?
vaginal estrogen will help a lot,
Okay.
actually. In and of itself, vaginal estrogen will help that incontinence. Not necessarily the stress incontinence so much that you have when you cough, sneeze, or laugh, but more that urge. When you go to put your keys in the door, you hear the water running, or you just get that urge like, I have to pee, I gotta go to the bathroom right now.
Yeah.
Vaginal estrogen is actually going to take care of a lot of that.
Really?
Yeah.
Is that over the counter?
No.
Okay.
Mini. Yeah. The peanut gallery says mini. Yeah. Yeah.
If you have migraine with aura,
Yeah.
use vaginal estrogen an option?
Yes.
What does she ask?
If you have migraine with aura, because it doesn't, like I use vaginal estrogen.
Okay.
Yeah, because it doesn't bump your systemic levels of estradiol. So yes, you can use it very safely.
Oh,
Yeah.
good to know.
Vaginal estrogen. Yeah.
Okay, I could ask.
Yeah.
What is the risk with the aura?
Stroke. Yeah. And blood clots. Yep.
So that's a vascular.
It is a vascular. That's the aura is letting you know you have like this vascular spasm. Yeah. That's what the aura is. Yeah.
So into menopause, I understand that you might still be producing a low amount of estrogen.
Yes.
Which if you're not testing, you don't know what that is.
Right.
But in terms of the heart disease risk,
Yeah.
will that low amount, if your body's still producing a low amount, will that still be counteracting the heart disease?
It's protected. That low amount's still protected for you. Yeah. So it's still counteracting it in that regard. It's protected.
So is the testing useful for that?
No. And yeah.
We're accepting new patients.
Always. And just like you, I do telemedicine on Tuesdays. That's a lot easier way to get in, and I'll tell you, talking about perimenopause and menopause can absolutely be a televisit. Every once in a while, especially with vaginal symptoms, I think an exam can be really helpful because I would just want to make sure I'm not just like, oh yeah, you just have like GSM, maybe you have something else going on. So I think with some GSM symptoms, an exam is really important, but really other than that, talking virtually is fine. So for me personally, get in way faster
and telemedicine, and to see in person is probably 3 to 4 months. Yeah.
How do we get the paperwork if they're all I'll post it on our Facebook page tomorrow. So Facebook, Flagstaff OBGYN LLC, and then I'll also post an update when we have the video ready to load. But yes, tomorrow I'll post the
You want to give her? Yes. Thanks. Yeah.
Is there anything that helps with the musculoskeletal things? Like I'm having issues, but it's all.
Yeah.
Besides starting
Right, hormones, and then just making sure that you're working out safely, not overdoing it. So sometimes working with a personal trainer.